Yeah, so there's two big things that happen to you though. So you have you
Yeah,
have your knee. So I
got
saw
my
you
knee.
walking better.
It's getting
And then
better.
good, okay.
Hey, there you go. So this is Willie. For those of you who are watching, got her on Tuesday night. She is adopted, rescued, I guess. Rescue, adopted, same thing, I guess. I don't know if there's a difference there, but picked her up. She is a mix of American Bulldog, American Shepherd, and a little bit of Blue Heeler in her. And so she's kind of looks like a chocolate lab, but she very much does not have any lab in her. But she's got this like extremely soft puppy fur right now, where it's just like she cuddles up against you and it's like, oh, it's just the softest, cutest thing ever. I know we were talking about a little bit of dog training before. This is the other thing, dude. I think all puppies are probably like this. But like, she will be dead asleep, and then as soon as she opens her eyes, she's like, wait a second, I get to play now.
Dude, it's on or off.
I'm gonna
There's
chew
no
on
in
everything.
between.
Yeah. We were talking about a little bit of puppy training before we started. Because you sent me some videos yesterday of you and your dog there, Christian, and I don't think I know anyone that has their dog as well trained as you do in terms of just like the way that bruiser listens to you and whatnot. And so we were talking about like kind of what you did and what worked for you and whatnot to help me training Willie here. And I don't know if this is smart or not. I've been putting her in her kennel during the day, but at night, I mean, who could resist Willie? She's been sleeping in bed with me. She's not made any messes in bed. When she's in bed, she doesn't make any messes. And when we get up in the middle of the night or in the morning and go outside, she is very good about holding it. But god dang, dude, just like laying in bed and she like burrows underneath the blankets and like cuddles up next to my side. And then I can just like feel her just dead weight pass out. It's the best. It's one of the best things ever, I think. But
Yeah, we didn't do that at first actually. Bruiser
yeah.
was not allowed on the couch or the bed for the first probably year and a half of his life.
Okay.
And then I made a huge mistake and we were playing way too close to some metal and he jumped onto it and slit his paw pad. I had to take him to the vet to get a few stitches and I didn't want him to chew the stitches off in the middle of the night when he's in whatever room or on the floor. And so I wanted him to be in the bed next to us so I could keep a better eye on him. And then ever since that fateful day, he has been in our bed.
That's funny.
Yeah, and I don't mind it. I think it's fine. He's not mean about it. It's honestly pretty nice.
Yeah, I know. I had like a coworker in the clinic tell me, like, can't let her in bed. Gotta resist. I'm like, I just can't.
Just depends on what kind of boundaries you want to set.
Yeah.
Like, we don't care about the couch. He always has a blanket that he lies on the couch.
Yeah.
And in the bed, he has his own separate blanket too. But there, of course, are other boundaries that he has to follow.
Yep. Right. Yep. So anyways, we're figuring things out. I have a tie blanket that I like to have on when we do these podcasts and whatnot, and she absolutely loves the tie blanket, and she's just down there playing around, chewing away. So we'll see how rowdy she gets. She likes to find my feet and start chewing on my toes. So if I start jumping or like sounding like I have a speaking problem, a stuttering problem, it's because Willie's biting my toes. Anyway, all right. So yeah, big updates there. The knee's doing a lot better too. I've been progressing from just like quad activation, range of motion to I've actually been working on like a lot of gait in terms of just like breaking down the gait cycle, finding out where like my pain points are in the knee. Like, is it the toe off? Is it the swing phase? Is, like where does the knee not want to move very well in? And it is mostly the swing phase. Like when I bring it, when I bring it through, kind of like that, the give or take 60 or, 60 to 70 degrees of flexion or so, like that's usually the painful spot. So like when I bring the leg through in the swing phase, it's a little like, tight. But I've been breaking that down and working on that in the gym. It's been feeling a lot better. Yesterday I did a little bit of single leg press, lighter weight on what it could tolerate. And then I did some barbell RDL, which felt amazing. Like it just felt good. Because if I load the quads, I can't go super heavy. But if I load like the hamstrings and the glutes, it feels just fine. And it actually feels really good. It feels like those muscles are like, we need this stretch, this loading. And so, yeah, I've been slowly progressing into some heavier weights and more compound movements. And it's been coming along well. There's still some swelling there. Like I could probably do a better job of, putting less stress on it, probably doing a little bit more just like gentle exercises. I'm probably pushing it a little bit more than what I should, but just because there is some more swelling that comes and goes that I notice. But for the most part, though, it's been coming along well.
I mean, yeah, for being, what are you, 2 weeks now? 3 weeks?
2.5 weeks
Yeah, that's pretty
from
good.
a
Good. That's a good
suspected
recovery pace.
meniscus tear. Yeah. So, yeah, it's been going well. I'm definitely lucky. I don't think golf season's over yet.
No, dude,
That
you're
was
gonna be just fine.
Yeah, that was my thing. I'm like, I don't want this to ruin golf this year, and I think we'll be fine. But
Yeah, you'll be good. You got about a month anyways.
yeah, it's still pretty. It's like I think this morning it was, what is it, 30, 36. It says still a
Yep.
little chilly out, but
Well, Eric, today we're doing something a little bit different. You are the resident expert on vestibular and concussion
allegedly.
rehabilitation, allegedly, and I'm not. I don't treat this. I haven't really treated this stuff ever. I have one patient right now. I'm starting to dip my toes into it. I have one patient right now with a vestibular issue,
Okay.
but I am in no way an expert in this field, and so I'm going to be interviewing you about concussion management, and we're going to be using the, I believe, 2020 clinical practice guideline on concussion management. And it's a hefty document, but this sort of document is exactly what physical therapists, rehab professionals need to be reading just to get a lay of the land on really any topic that's out there where these are published. And so I read through it. There's a lot of stuff I don't know, a lot of big words. And so we're going to need you to break all that down for us. But we're going to start
Hopefully,
yeah, we're going to start pretty simply though.
okay.
So I had a list of questions. I'm sure you saw them. I just want to start with, what is a concussion?
Yeah. So concussions, they can range from, obviously, we all see the scary hits in American football or in football in Europe or across the pond there, like when they go up to hit the ball at their head and they collide head to head, or someone takes a big hit on the field. Or I even had one in basketball where I took a charge, I went down, I kind of like whiplashed my head, back of the head into the floor. Like, they can come from many different things. Even a motor vehicle accident is a huge one that we see a lot of concussions in vestibular care. So motor vehicle accidents is a big one, and that's because we don't always need like a big collision or a big hit, right? You can have just like a pretty minor whiplash and you can get some pretty bad concussion symptoms from it. Or obviously, like I said, you have the ones where you see someone just get annihilated on the football field. They're out for several weeks to a month or so because of a concussion. And it's like, yeah, I can understand why you got hit pretty hard there. And so first off, I just wanted to talk about that in the sense that, like, let's say someone rear ends you and you kind of like whiplash your head a little bit, and then you're getting these terrible concussion symptoms that we'll get to later. And it's like, well, like I barely hit my head. Like it can't be that bad of a concussion. And it's like, well, no, it actually can be. Even just a minor mechanism of injury, like a rear end at 5 miles an hour, a little tiny whiplash, that can cause, for the right person in the right scenario, some major concussion symptoms, just like a football player getting annihilated on the football field can also have the same effects. So with that being said, when you break down kind of more of the pathophysiology of what a concussion is, that's where we get these different shearing forces and different forces within the brain that causes like anatomical neuronal damage, axonal damage. So these neurons, axons of the neurons, where we see this kind of breaking. I mean, they don't like completely rip apart and your brain is a big mess. It's a way to describe it. I always feel like when I describe this to patients are like, oh man, is my brain all torn up now? It's like, no, that's not the case. It's not all torn up. This shearing forces within the brain that causes this disruption of these different neuronal parts. And that's where we start to get these different symptoms. Because what happens is there's only so much blood flow that goes into the brain. There's only so much blood flow that goes off of the brain. And so the reason why that's important is because our brain is very efficient and actually uses a lot of energy just sitting here as is. Now, apply an injury to that somewhere in the brain, and now you just added X amount more energy needed to heal itself and still function and do all the things it needs to do. And so it's this kind of energy crisis within the brain. And it's that energy crisis that people feel, this variety of symptoms, whether it's, a lot of fatigue, sensitivity to light and sound. They have poor like aerobic conditioning, because as soon as they get their heart rate up and the brain starts using more oxygen, etc. And then again, it's kind of that energy crisis. So once that comes into play, we start to see people get worsening symptoms. So concussion is really, it can be like either a big hit, it can be a small whiplash. And what we see it evolve into are these different neuronal injuries within the brain that can happen in different areas, but different neuronal injuries within the brain that then causes this energy crisis, which then promotes all these different symptoms that we can see.
Yeah, so my general basic thought is it's kind of like a bruise in your brain.
Mm-hmm.
And with that, there's a lot of healing that has to take place. Your nerves aren't functioning normally. And when your nerves and your brain don't function normally, you have changes in how your brain and your eyes and balance systems and even the way your body physically moves. Those changes can be quite severe for people.
Yep.
And then
Absolutely.
Okay, yep. And I feel like I've been hearing more about concussions over the years. I think it's one of those things that we probably knew was bad, but didn't study it a lot or didn't want to talk about it a lot. It was kind of taboo. And then in the last decades, it's become more front of mind, I think, because we've seen those older football players, for example, in the U.S., have major issues later in life in their 40s, 50s, 60s. And we want to make sure that we're not setting kids up to fail later in life, just for the sake of sport and entertainment. And also, I think the clinical practice guideline brought up a couple reasons why we think about these things more. They said there's clearly more media presence, more media coverage. That's just the state of our world these days.
Social
so perhaps
media.
Yeah, that makes it all seem like maybe a much bigger problem than it is. But I don't really think it's overblown. And then you kind of mentioned too with those small motor vehicle accidents where some people don't go to the doctor.
Not reported.
Yep, they're underreported and unrecognized. They don't even know. They're like, oh yeah, my neck is sore, my head's a little sore because I was in a car accident or I fell. I fell and hit my head a little bit, or I got jostled, and now I'm just off for a few days. That was probably a concussion that you did not seek medical attention for, and we don't get a clear picture of how many are actually happening. And the numbers were pretty staggering. In the document, they said that we don't truly know, but we have roughly 1.6 to 3.8 million concussions per year from sporting events alone. And then they said that 12 times that number from other causes like motor vehicle accident, falls, and even military injuries. And so that's a lot of concussions.
A lot of concussions.
Yeah. Anything you want to add to that?
Well, I think I don't want this to come off as like you don't need to seek medical attention, but I think the other part of it is like, I guess there's a silver lining that like if people get a concussion, they don't have to go in and seek medical attention right away. It kind of gets better on its own, right? And so to that point, I think it's fair to say that like our brain and our nervous system and our vascular system and our immune system is all very, very good at recognizing injury and damage and repairing itself and being resilient within that process, which is great, which is awesome. But still, if you suspect a concussion, you should go in and get checked out.
Gotcha. I do want to talk now about why are concussions bad, especially like the ones that are not just super minor and you end up being fine on your own. But so why are concussions that are a little more severe bad, and why do we need to treat them? Or should we even treat them?
I think I'll, go after the last question first on should we treat them or do we need to treat them? And in the CPG, it talks about how there's no like hard evidence on whether early concussion rehab is either safe or dangerous. Like there's not a whole lot of research done on that. And so what they say is like, we don't have any data to show it's dangerous to do concussion rehab within the first week of an onset. But there is some like preliminary case studies or case report series that show there's actually benefit of doing early low intensity concussion rehab for those individuals. And so I think we should do it. I think it should be early. I think that we should get involved especially as physical therapists, but just healthcare professionals in general, I think should get involved with this early concussion rehab program, kind of no matter if it is a super severe one or not so severe. Now, going back to the other part in terms of like, I guess the dangers, right? I'll just say a story, for example. I had an athlete come in and he got a pretty nasty concussion, and another healthcare provider was like, don't stress out your symptoms at all. Like, you need to rest. You need like all these things, right? Like if you feel your symptoms increase at all, you need to stop what you're doing And I was a little bit more like, it can get up there. Like, if your baseline is a 5 out of 10 and it gets up to a 6 or a 7, you're going to be fine, right? Obviously, if your headache goes from a headache to like an absolute splitting, sickening headache, like 10 out of 10, maybe we should stop and, get checked out. But with that being said, just because I've seen like long-term concussions that don't get treated right away, and people come into the clinic after like a workers' comp injury, and they've had concussion type symptoms for like 6 months when they finally go in, and then they come in, and it's like, dude, you've been living your last 6 months, you've been living your life with these terrible concussion symptoms, and like, yeah, they're not getting better. They're not getting worse, but they're just kind of, this is like your new normal type of thing. But like nothing detrimental has happened to these individuals, right? And so I would say for that reason, I'm a little bit more toned down when it comes to like, can't stress out the brain at all. You can't increase the aerobic activity at all, or all these other things. I think the biggest thing when it comes to the concussion portion is like the dangers are more so in like our older individuals. The older individuals that now are at bigger risk of falling, they might be at bigger risk of having like some type of a hemorrhage, or, being more predisposed to the cognitive portion of it. So I think in the older population, there's some more quote dangers when it comes to concussions. But I would say in terms of like the younger population, more the athletic sport population, it's just all about monitoring the signs and symptoms. We're not too concerned that like, if you get a concussion and then you go to bed at night, that your brain is gonna explode or whatever it is. Like, that's not where we're at. But there are implications as well for in the future, especially for younger individuals. If you have 3 or more major concussions, we get more concerned for future brain health. There is that, because it can have an impact on it, and we see that in these different studies now coming out, especially from like the NFL. So yeah, I would say more of the concern lies in the older population because of the different sequelae of effects that can happen. In terms of the younger population, if it's a standalone concussion that is, managed well, I'm not too concerned about any dangerous aspects of it. But if we start to have several in a row of those, now we start to, look into the future and think, what could this mean for your brain and nervous system health in the future?
Yeah, that's really helpful. I wasn't aware of that 3 concussion. I don't want to say cutoff, but just once you have 3, you start paying more attention. We should consider changing what you're doing so you stop getting more.
Yeah, and I think that that number might, it's like ACL rehab, right? Some surgeons do open chain knee extensions week 1, and some surgeons are like, don't you dare do a knee extension till like week 8. So I think it's just also as things come out, we learn more, we adapt more. Some people it might be 2 concussions. Some people might say 4 or 3. It kind of just varies in terms of, I think, who you ask.
Yeah, and then is it like low back pain and let's say shoulder instability, where once you have low back pain once, or once you have a subluxation or dislocation event in your shoulder, you're more likely to have those things happen again? What's that like with concussions?
If it's more like the acute phase, I think we might have all seen these videos. If not, if you don't mind graphic things, it's not like graphic in a bad way, but like when Tua Tagovailoa, the quarterback for the Miami Dolphins, like week 1 or whatever, got hit hard, and he went into a decorticate position where his hands and everything came in like this. That's just a sign that basically the nervous system just went haywire and he just went into this curled in position. When that happens, we see that and we're like, that looks dangerously serious, right? But then I think like a few weeks later, he comes back and plays, get hits again, and then goes back into that same position. So when it comes to like more acutely, if we don't give things the proper time to heal within the first couple of weeks or a month, etc., and then we could be at a higher risk of, a little bit more sensitive to different forces in that head and neck region, versus if you had a concussion last year, 2 years ago, but you did the rehab, you got back from it, you've been living your life like normal, and then at that point we're not as concerned to say like you're at a 3 times greater risk of getting another concussion. I don't see the data on that. I think we used to think that like if you had a major concussion before, now you're going to get another major concussion if you hit your head again. So you actually are not at any greater risk in the future if you have that or not.
Oh, that's helpful. That's also just reassuring.
Yeah.
But like what you're saying is, if you have one, even if it's minor, you need to make a full recovery before you start doing more risky
Yeah.
things.
Yeah.
Yeah.
And I think I saw in the question, like we'll get to kind of what is that full recovery and like kind of what is,
Yeah.
what do we look for in that? But yeah.
Yeah, so let's talk about symptoms. So ones that I think most of us think about are going to be headache, dizziness, maybe some nausea. But what are a lot of those other concussive symptoms?
Headache, dizziness, nausea. Those are probably like the three biggest. Light and noise sensitivity. So photophobia, is it phonophobia? Well, I guess that's like
Yeah, that sounds right.
fear, but I think it's the same thing pretty much. But anyways, yeah. So light and noise sensitivity, you can get we have seen pretty gnarly BPPV from concussions. So getting struck in the head, and younger individuals especially, they get those crystals loose in the ears. They go where they shouldn't. And we get some pretty gnarly BPPV from it as well. That's another symptoms. That's the room spinning when you lay down in bed, rolling over in bed, the room spins. That's what that is. Balance is another one. And so one of the things we see with concussions that with vestibular therapy, we really look at is the vestibular system. And so we look at the balance system, we look at your vestibular ocular reflex, which is a reflex and ocular motor reflex in between the vestibular system and the eyes. We want to screen that stuff because that can greatly affect your balance as well. And then, going ahead with this one too, the neck and like the upper back, that can greatly come into effect, especially depending on like what the mechanism of injury was. We know that the upper cervical spine has a lot of communication with the brain in terms of where the head is at in space. And we can see things like our suboccipital muscles or, kind of those upper cervical paraspinal muscles, C1, C2, C3 in that region, where if they get, I'll just say dysfunctional, they don't want to work like they used to before you got in a vehicle accident or whatever it might have been, that can also cause not only neck pain, reduced range of motion, a lot of stiffness, but also it can influence the headaches and the dizziness and all of these other symptoms. So the neck is another thing we really try and look at. And then we also know, even without concussions, if we have a whiplash injury, we know that neck pain with whiplash associated disorder, we know one of the hallmarks of that is actually the deep neck flexor reduction in strength, that they kind of, they just don't want to be working as much as what they did before the whiplash. And so we can see that reduce in terms of how well people can be holding their head up over time. And that can influence pain and symptoms as well. So we have a variety of things. I would say the hallmark signs would be the headache, dizziness, and nausea. But then we also have light and noise sensitivity, balance issues, possible BPPV, a lot of cognitive, so lack of concentration. A lot of people just kind of feel this like fogginess in their head. If they try to read something on a piece of paper, they maybe get through like one line. And then a lot of times you'll see people kind of like do this, like they're trying to like reset or something. It's just because, again, cognitive function. It all comes from the same blood supply in the brain there in terms of what's coming in and coming out. So they have this reduced, I guess, endurance for cognitive ability. You can see things like memory issues. So, people might get a bad concussion and then they go home and they're like, wait a second, what was I going to do? Like they walk in the door, it's like, was I going to make dinner or was I going to go sit on the couch? So like we can see some like just like short-term lapses in kind of that short-term memory of like what people were aiming to go do. And then lastly is going to be aerobic conditioning. And so you'll notice like walking upstairs to go to bed. You just walk up a flight of stairs. By the time you get to the top, your headache greatly increases. You feel very fatigued. Maybe the lights got really bright. Whatever it is, your symptoms get amplified again because that lack of aerobic conditioning because of what's going on with that energy crisis within the brain. So as you can see, there's a lot of different symptoms. As I'm talking, I'm kind of like getting triggered more and more things that can be coming on. But yeah, the big three, like you said, the light and the sound, balance, dizziness with BPPV, lack of concentration or memory, focus, lack of aerobic conditioning, neck pain. That's over 10 symptoms right there. So, there's a lot of things that can come on after a concussion.
Yeah, tons of stuff. I think that was pretty much all the ones that the clinical practice guideline touched on. And it's tough because we don't always know why all these things happen. We don't have the clearest explanation. But I did want to quote one explanation that I thought was just fun to read. It says, it has been hypothesized that concussions can lead to an uncoupling of the central autonomic nervous system and the heart, leading to a reduced ability to maintain and adjust cerebral blood flow, blood pressure, and or heart rate in response to increases and decreases in physical exertion. So
That's a
dumb
goddamn
person read,
mouthful.
dude, I know, my dumb person read of that is
Jesus.
your brain and your heart are having miscommunications,
Yeah.
and that's leading to you feeling some symptoms. But like, how do you take that?
Maybe. How are we gonna like prove or disprove?
We don't
it,
actually. Yeah, it was a theory.
Yeah, right. Yeah. I mean, it's one of those things. Like, yeah, it sounds good. I mean, it's the same thing. Like, dude, like I think I asked you this the other day. Someone on their social media posted that they were getting like their vagus nerve mobilized. And I'm like, hey, did I miss something in PT school? Are we able to mobilize the vagus nerve? It's like, yeah, you can make it sound fancy and like it, use big words and make it sound like it should be the real thing. And maybe it is. I mean, the autonomic nervous system is very much a part of how we function throughout the day. The only thing I have a hard time to come to grasp with is like, it's autonomic. It's automatic. We can't control it. If it is the automatic part of our body that we can't control, and then how do we control the symptoms to make it better? You know what I mean? Like,
Yeah.
So and then like, what's your proposed, what's the proposed mechanism of making it better? I wouldn't completely throw it out the door just because it's, I don't think it's completely out the door, but I wouldn't buy into it all the way. But we do know other things like, one of the things I forgot to mention, emotional distress, like people having poor emotional regulation, people getting very frustrated after a concussion, or, people can get really sad after a concussion. It's just this can have a big effect emotionally as well. And so, again, it's like that emotional part, like people aren't trying to be extra sad, but we know it's associated with symptoms of a concussion. And so like, if that's the case and we accept that, and then I wouldn't completely throw away this autonomic brain heart dysregulation, but I wouldn't say it's the truth behind why it's happening.
Yeah, and even if it was true, like, what are you actually doing about it?
What are you
Which
going to,
we will kind of get into in
Yeah.
a moment here with how do you treat concussions?
Yeah.
All right, so just before we get into how to treat them, I just want to do a quick, what are the really bad symptoms that we should know about? And then how long is concussion rehab on average?
So the really bad symptoms that we should know about, the headache is one of them. Just because like we're thinking about like red flags at this point, right? So if you get a concussion, you go in, you get checked out, and they seemingly don't find anything else that's emergently wrong with you. It's just a concussion. They send you home and you start doing PT stuff or whatever. And if I have a patient at this point telling me that, if they're telling me that their headaches are like, yesterday it was a 3 out of 10 and now today it's a 10 out of 10, and I can barely walk, I'm getting really sick, their vitals are, their heart's racing, not doing anything, or kind of these more off signs and symptoms, that's when I would be more concerned that there could be something else going on behind the scenes, right? Is there a missed hemorrhage somewhere? Could there be something going on in that upper cervical spine that wasn't screened and caught in terms of like needing x-ray or imaging? And so I would say those are the biggies to keep your eyes on, is really the headache for sure. But if your symptoms just out of nowhere go from like pretty average to just bad shit crazy, and you didn't really do anything to make it that way, that's concerning in terms of, okay, is there something else progressing beneath the surface that we need to take a deeper look at?
Yeah, I read about some different tests that we have that we can use for folks. You're going to use the Glasgow Coma Scale. There's the Canadian Computed Tomography Head Rule. And we use these different tools just to get a judgment of severity and if we should refer someone to the emergency department, for example.
Yeah.
One that seemed pretty simple to understand was They said signs that CT imaging, so CAT scan imaging, and other acute monitoring are not likely needed include normal mental status, no loss of consciousness, no vomiting, non-severe injury mechanism, no signs of skull fracture, and no severe headache, which is stuff you kind of said. But I think just keeping those general ideas in mind where if there's some crazy bad stuff is going on, like you were passed out for a while,
Yeah.
or you clearly are not mentally functioning normally, we're taking this pretty seriously.
Right. Yeah, I left out the loss of consciousness, right? That's another biggie. Also, the vomiting, that type of stuff. That's in there. And like again, it's all about kind of like, is this tolerable, normal concussion symptoms? Yes, it sucks. It's not fun, but can you hang out at home and be able to tolerate it? Or are these things going, like I said, just bad shit crazy and they're progressing a lot? And there could be more concern for something more progressive going on underneath the surface. And kind of like you said, Christian, it's almost like if it looks like it would be bad, it could be bad. So like if you fell off a 20-foot roof and landed on your head, that could be bad, you know? Like if you hit your head and you were passed out for an hour, that could be bad. If you hit your head and you can't stop vomiting and your headache is a 10 out of 10, that sounds like it could be bad. And so, like, I don't think that there's necessarily clear cut, like, clinical prediction rule, 3 out of 5 symptoms, you're probably having a stroke. It's more of like, do things look bad? Are they getting really bad? And like, if they are, and then we should probably get a deeper look into it. If they aren't, and then we're just going to hang out, monitor, see how you feel throughout the day and throughout the week.
Cool. Well, let's start getting into some treatment. So I was reading about the 4 major body systems or body regions that physical therapists need to focus on when it comes to evaluating and treating people with concussions. And so those 4 areas are cervical musculoskeletal function, vestibulo-oculomotor function, autonomic dysfunction / exertional tolerance, and then motor function. Just what are your thoughts on those 4 different categories, and how do you like to treat those?
Yeah. I think for me, they kind of all meld together. I think the motor function is tied into the vestibular ocular function. I think the cervical function is tied into the balance function. I think a lot of them are playing into one another. And then just overall the exertion, right? The dysregulation, the lack of aerobic conditioning from more of a symptom provocative standpoint, I think is also just crucial in how it plays its role into everything. But with that being said, I like to first treat, when it comes to concussions, like I said, is screening for BPPV. Make sure that's not there. Because when we start out, what's the low-hanging fruit and like what can you tolerate? So like one of the low-hanging fruit to fix right away would be BPPV. So like if they have it, great. We can take care of it, move on, go to the next thing. After that, I mean, going back to what we've talked about before, I think even plays into this a little bit, Christian, but with the cervical spine, kind of our rehab and what Chad Cook had to say about treatment of the cervical spine between exercise, manual therapy, and both. You're just kind of treating the cervical spine like you would treat any cervical spine patient. So as long as you screen that upper cervical spine and ligamentous and range of motion and whatnot is intact and good, well, now we start working on deep neck flexor training. Now we start working on stretches or range of motion to try and loosen up or lessen the tightness in that back of the spine. Maybe we do some hands-on manual therapy work. For me, I like to do dry needling. For example, again, the patient I had just the other day with the acute concussion that I saw, like we dry needled his suboccipitals because it's not exertional at all. It's a very safe thing to dry needle. And for him, those things were just fired up. And so we put some needles in his suboccipitals, and like a couple days later, he's like, yeah, my neck doesn't really hurt anymore. Now, again, is that natural history or is that the dry needling? Probably a little bit of both. Who knows? But so then I think that like treating the cervical spine in terms of like symptom provocation, it's not going to provoke the symptoms as much, right? So again, we're looking at low-hanging fruit, lower intensity right away. So what is that going to be? That's going to be the BPPV. That's going to be cervical spine treatment, because a lot of that stuff you can do lying down, sitting in a dark room. You don't have to be using your eyes, right? You can do a lot of that stuff without provoking the symptoms a whole lot. I also like to do what's called a Buffalo concussion treadmill test. And so that's when you uh, get them on a treadmill, you get their heart rate, their exertion level, you have them walk, you increase the incline, and then you have them keep going until their exertional levels hit a certain point, or their symptoms hit a certain point, or the patient just calls it quits, etc. And then you take that number. All right, this is where we got to. Let's say a patient can walk 4 minutes before they reach their point, right? And then, I'll probably have them be like, all right, I want you 3 times a day just to get up and take an intentional 3-minute walk. So it's right below that threshold, but they're getting up and they're walking and they're getting some movement in, and then they're chilling out again. And we're just taking small walks throughout the day, if that's 3 minutes, 5 minutes, whatever it is. So that's probably what like the first week or two would look like. Now we'll get into the vestibular ocular side of it as well. I found that to be like the most like provocative in terms of people with concussions. Because think about it. They have sensitivity to light, so they don't like it when their eyes are open. They have balance issues, so they don't like to test their vestibular system in the balance system. They don't like to be moving their head fast. They're not very good at concentrating. Like all these things that concussions present as, that's what you're going to ask them to do, right? So we can just start out with smooth pursuits, or we can start out with like a VOR cancellation, or like a VOR 1 where you turn and watch the finger at the same time. Those are all, by the way, tests that we do as well to see how provoked are your symptoms. Like I might have you do a smooth pursuit, and like if they're like, yeah, that was fine, I didn't really feel much, I'd be like, perfect, we just found our starting point for ocular motor, or like I might have them do VOR 1, and after it's done, they're like, oh, I'm fucking blasting off right now. Like, that sucked. And it's like, all right, we're not doing that for a while, But you get kind of these starting points from it. So and then eventually I have them work into the ocular motor side of things, right? I'm doing some of those different reflexes when it comes to like tracking or gaze stabilization. But that's usually not for at least after week 1 until we have a good grasp on the symptoms. Because I don't want to give them something that's going to provoke them and send them home with it, and they come back and their symptoms are worse because they've been pushing things too hard with the ocular motor. And so I usually wait on that one for a little bit. I like to stick with the cervical and light aerobics, that type of stuff right away. And then lastly for me would be then the balance piece. So we have some different balance tests. One of them I don't think was mentioned in here, and that's because I learned it through my continuing education courses at the American Institute of Balance. I really like it. It's called the GANS SOP. I think his first name's Richard, last name GANS, so of course he names the test after himself. But the GANS SOP stands for the Sensory Organizational Performance Testing. So it's just these different balance tests with the feet on and off foam, different positions, eyes open, eyes closed, and you kind of get a sense of like where their falling off point is and if the vestibular system is impacting their balance at all. And I like to do that one because it's very safe and it's very easy, and it doesn't really provoke the symptoms, but you can tell when the patient is like having trouble with the balance. So then it's like, oh, okay, foam, eyes open is pretty tough for you. So I want you to get a couch cushion or a pillow or something at home and stand on it with your eyes open next to a wall, something to grab onto, and do 4 rounds of 20-second balance holds, right? That's usually a pretty good starting point when it comes to the balance point. And then, yeah, just like over time, now we're just going to progress these things. As things start to feel better, maybe week 2, week 3, whatever it is, depending on, I mentioned that patient that came to me with a concussion for like 6+ months. Like, man, it was a hard rehab session to get his symptoms to come around. It's like if you break something or tear something or hurt something and you wait 6 months and now your range of motion in your shoulder is 50%. For 6 months, it's just the same thing, but it's just in the nervous system. And so like there's really not a magical transition to make. It's like the brain, the vestibular system, all these things, they're plastic. They can change, they will adapt, just like musculoskeletal things will. And so for him, we worked on his vestibular stuff for weeks to months, right? Whereas like someone who has an acute concussion, young and healthy, by day 5, we might be progressing into some more advanced stuff. It just kind of depends on the health and the history and the duration of symptoms in terms of how quickly we're going to progress. But eventually, we're going to get to some more challenging things where we start really pushing your aerobic conditioning. Now we're carrying weights, or we're pulling weights, pushing weights. We're going to be walking with head rotations while playing catch on a single leg, and you're going to list me off the capitals of different states. Like, get the cognitive part going as well. That's more of like the end rehab sort of stuff to really solidify what we've been working on. And then at the very end, we're going to retest everything. So we're going to do that Buffalo concussion treadmill test again and see how well you're doing at that. Screen the neck, make sure the neck is no longer painful or in play. We're going to take a look at the ocular motor reflexes, make sure those are intact and non-provoked. We're going to really test that balance out and make sure that's good to go. And yeah, we have patient-reported outcome measures that are validated, like the post-concussion symptom severity scale. We'll probably be tracking that throughout the different weeks and as we go as well. And so, yeah, I mean, you can see that there's a lot of different avenues that you can go down, but that also means that there's a lot of different things that you can work on. So like, if you have a concussion, and like I said, if trying to focus on something or track something just blows up your symptoms, that's okay. We can do balance in a place where you don't need to be focused on anything. We can do cervical exercises. We can do a little bit of walking, right? It's nice because you have options on what you want to work on in those initial phases while the nervous system continues to recover from whatever insult it was.
Gosh, I have so many thoughts. Well, I'm just going to start with one of the first ones I had, which was, I like what you said about, meeting the patient where they're at, like anything.
Yeah.
There isn't a strict protocol or a script that we follow. We're making this up as we go based on what we're seeing with you. And every single person, every single concussion is very different. But you said for low-hanging fruit, you want to clear their vestibular system. So if you impact your head, you might shake one of those crystals in your inner ear into a place it shouldn't be, and that can give you vertigo. And if you are the physical therapist trying to assess, okay, why does this person have dizziness or vertigo? Is it because their brain is really sore, or is it because of these crystals are out of place? Try to fix what you can, check that. It takes a second to do anyways. So that makes a lot of sense.
Quick and easy.
Yeah. And then also look at the neck. If someone hit their head, it's like rolling your ankle. When you roll your ankle, the ligaments and the muscles and the tendons get overworked suddenly from having to reflexively try to control all those forces, and they lost. In the neck, same thing happens. Your spinal ligaments, your spinal muscles and tendons, they get strained and sprained, and that can cause a lot of tightness and soreness. And we know with the neck that tightness and soreness in your neck muscles can cause headaches, can cause dizziness, and all sorts of different things that people experience. And if we can clear out some of that by massaging the stuff, stretching it, doing some gentle endurance exercise work, dry needling, that can help us get a clearer picture of what the patient is truly feeling from more of the brain stuff as opposed to the neck contributing. And also just makes them feel better sooner. So why wouldn't you do that?
Exactly.
And like you said, it's pretty easy to work on the vestibular system, at least with the BPPV stuff. And it's easy to work on the neck because they can be in a private room. It can be dark, and they're lying down while you're massaging their necks. Like, that's pretty chill.
Yeah.
And then you said, okay, once we hone in on these symptoms and we're more dialed, then we can begin to work on the stuff that we know is going to piss them off. So that's where you start moving or working on the eye tracking and the head movements, which makes their brain work harder. And when your brain works harder after a concussion, you can get some symptoms like dizziness. So if you pull a muscle and you work the muscle too much, it gets sore and it hurts. In the brain, you get different symptoms like dizziness and headaches. And so we're just trying to figure out what exercises we can do to meet your symptoms where they're at and help encourage that adaptation, encourage that plasticity so that your body can repair and recover, ideally a little bit faster. And I like that you mentioned thinking about more of the athlete, regardless of their age, where some of these more difficult phases are going to be you doing cardio. You get, maybe early on, it's very low intensity cardio. Maybe it's walking on a treadmill. Maybe it's on a stationary bicycle. And you're just trying to encourage blood flow, encourage cardio to get the body used to the movement of blood in their brain again, which can be quite sore. Plus, cardio just helps heal you faster.
Mm-hmm.
And then progressing their exercises as well, maybe starting with very simple shoulder blade and neck exercises and eventually getting to, like you said, some carries or heavier dumbbell rows or just things that work your upper body more extensively. And there's so much that you can do. like we said, there's 4 different systems. You have the neck, you have the vestibular system, you have the exertional tolerance, and the general motor function, which is like strength and
Hmm.
conditioning stuff.
Right.
You're doing all these different things at once, just scaling them up in accordance with the
Yeah.
client's symptoms, their severity, and their goals.
Yeah, absolutely. And yeah, you laid that out really nicely. It's each person's different. Not every concussion rehab protocol that you bring up is going to be the same. They might look similar, but they're not the same. And it's this fine, just like you're towing the line, going. You're not trying to get under prescribed or over prescribed, and you're trying to toe that line so that they don't feel too shitty, but they also get better. And the other thing too is before you do all this, you got to educate them. You got to like the patient has to trust you, because if you send them home with stuff or you have them do stuff in the clinic and their symptoms get worse and they don't trust what you're doing, they're either A, not going to want to come back to you, or B, not do what you tell them to do. Because if you can't get the patient to buy in and trust you and you're just going to make them feel worse, why would they want to keep going, right? And so that's the other thing too, as a physical therapist, like we have to educate the crap out of what's going on and also just make them feel like they're in a safe, controlled environment. One of the things I wanted to add as well, I've had an athlete with a concussion who he has a history of some lower body injuries, and they're finally getting better, like to the point where he doesn't really notice them, and then gets a nasty concussion. And now one of the thoughts is, well, damn, now my hip pain, my ankle pain, my knee pain, whatever it is, like, what if that comes back now when I try and come back from the concussion? And it's like, we could still do rehab stuff for the lower extremities. I just told him, as long as your like heart rate and blood pressure doesn't go up, you're not really doing much in terms of like aerobic conditioning. If you're just doing some simple hip internal rotation stretch or some different ankle inversion eversion exercises or some long arc quads like with low weight, we can still train other parts of the body. But I just really emphasize, like, we don't want any Valsalva maneuvers, right? We don't want to be grunting and holding and bracing our abdomen too much. If you start to feel your heart rate go up or your symptoms increase, maybe let's tone it down, because we're going to be doing that later in the day anyways. As long as it's controlled and mild, yeah, you could do some lower body training as well. Like, it just all depends on what that patient wants to do or like what their goals and aspirations are after concussion rehab.
And I think just like any musculoskeletal or orthopedic rehab, when you have an athlete, whether they're 15 or they're 40 and they're playing just tennis with their friends, when you have an injury like this, you are going to be deconditioning. Or your body doesn't wait for your brain to heal and keep all your muscles and everything strong and ready to go. They start to get a little weaker. They start to not perform as well as they once did because you're no longer using them in that same way. And a major thought for us as physical therapists is, if you want to get back to doing these things that you care about, you need to be trying to, if at all possible, preserve the strength and the endurance and the control that you've already built up over all these years while you're also recovering from this injury. And so that's where you really want to make sure you're trying to, like you said with your athlete, keep training your legs in ways that you can tolerate, or train your arms, or get some low intensity cardio and keep your cardiovascular system, cardiopulmonary systems functioning as best you can to mitigate those losses, because you will assuredly have some losses. And it's important because if you, let's say, have a concussion and you need to take 1 to 2 months off, and you didn't do anything, you didn't really do any extra strengthening, and you want to get back into soccer. The second you go back to soccer, you are a worse athlete than before. And now you are at a greater risk for other kinds of injuries. And so we want to make sure that we're thinking about you as a whole person and getting any of those other potential issues that could arise from a period of deconditioning and recovery.
Yeah, I think you said that really well. I'll just double down on what I said before. Everything is individualized. Not every person's going to be the same when it comes to it. But you're completely right. I'm just, as you're talking about that, I internally had a little tear going down my face because yesterday I was hanging out with a buddy. I'm like, dude, do my quads look smaller? And I pulled up my shorts and dude, my left quads, I'm so sorry.
They're just gone, toast.
It's like, oh my God, it's been 2.5 weeks and they're just like, I feel like they're just like
wasting
up.
away.
But it's a real thing though. Like, that stuff happens.
Just the way it is. That's life.
Yep.
So the last thing I want to talk about, is this going to be, how long are we talking for concussion rehab? I read in the clinical practice guideline that it can be a matter of a couple weeks to a few months is pretty typical. At least that's what they said. When you want to educate your patient, you want to make sure you let them know that most folks recover from these things fairly well, in fact, quite well over this rough period of time, and we're going to help you get there the best that we can. So what are your thoughts on timeline of recovery?
I would say most cases in that couple of weeks standpoint. Again, unless you jacked up your head a month ago and you were almost back, and then you jacked up your head again, and this time your symptoms got a lot worse, and now, physicians and whatnot, they're like, hey, let's maybe take things a little bit slower, a little bit easier. All right, now we're maybe looking 1 to 2 months out. But like, for example, young, healthy athletes that haven't had a concussion before, or they're fully recovered from their last concussion, they hit their head and it's like, you're 21-year-old healthy individual that's very fit. There's no reason to think, give or take 2 to 3 weeks, you'll be, back playing your sport. And of course, there's always caveats to that, right? Some things can come up. Some people just don't respond as well to things like we think they should. I've had someone just recently that we went really hard on, got hurt early in the week, saw them later in the week. So definitely within the first week of concussion symptoms, we started rehab. Within a week of starting the rehab, they're already symptoms are pretty much gone. And they're already working back to return to play. So it can be really quick. If they're very healthy, non-predisposed, etc. It could also be not as quick if, let's say, they're 50 years old with comorbidities and cardiovascular disease, and the symptoms have been going on for a while. At that point, now you're getting into a lot of other stuff as well. But I guess other things that can affect the prognosis of their recovery. So, yeah, I would say a couple of weeks, unless it's a unfortunate situation, and then 1 to 2 months, maybe even more, unfortunately, depending on the health of them and what they're presenting with.
Cool. Well, I think this was a really, really good conversation. I learned a lot.
Well, good.
Well, one, from reading the clinical practice guideline, but two, just hearing you. I think you did a really good job laying everything out and making it not seem scary as a clinician who doesn't currently treat these. And then for anyone that's listening, I think it just gives people a pretty clear understanding of what we're looking for, why we take certain things seriously, what the general timeline is going to be, what we do about it. All that different stuff I think is really good for young athletes or for parents who are listening for their kids.
Yeah.
Just what should they be looking for with their kids' recovery?
Yeah.
So thanks, Eric. Thanks for lending us your expertise.
Yeah, of course, man. No, I appreciate it. I think that the other thing too is I think just the complexity of it can deter individuals from wanting to either treat it, or people from wanting to be more aggressive with it than what they think they should be, or very afraid of it. That's what I said in the beginning. The brain is plastic. It can change. It can adapt. And we can treat it just like we would a pulled hamstring in a sense, right? Just you're treating different ways and you're prescribing different things. And so that's number one, I would say, for a closing remark. Number two is if you suspect something going on, or you did hit your head, or your kid hit their head in sports, whatever it is, I would, get it checked out by a healthcare professional. Hopefully there's an athletic training staff on the premise. If not, take them on in and get them checked out, or, maybe call your primary, see if you can't get them in the next day with the primary doc to get them checked out if you don't want to go to an urgent care or something. But just to have an established baseline. And then lastly, obviously I'm going to advocate for this, but I think vestibular therapy, we have huge roles that we can play. It doesn't even have to be a vestibular therapist. I don't want to volunteer you, Christian, but I think after having this conversation, hearing you talk about it, I would feel confident and comfortable that if someone came to you with a concussion, you could get them back safely and efficiently. And so I think a lot of PTs are able to do these protocols when it comes to concussion or vestibular and do them well, but I just don't think a lot of people know about it. I've had people reach out to me and be like, hey, you're a PT, what do you know about concussions? Where should I go? Where did the message get lost? Or is the message never sent in the first place that PTs are very valuable and we can do a lot with concussions? And the other great thing too is everything we talked about is you can do it at home on your own. A lot of things we talked about, you don't need to go to a gym. You don't need to have special equipment. You don't need any of that. You need a finger to look at. You need a place to walk. You just need some guidance on neck exercises and balance exercises. And like, that's it. You can get like 80% of the way there just by those things alone. I think it's very affordable, attainable, safe, good to do. And I think that vestibular therapists and just PT in general, we're a little bit of like an untapped market when it comes to concussion rehab. And that's no hate on our AT friends or physician colleagues or chiropractic colleagues, friends, whatever you want to call them. Just, we all have a role to play. But I think that what we learn as vestibular therapists and PTs, I think like we have a vital role and we have a lot to offer in this context.
Cool. Well, thank you. There's, of course, lots more we can talk about, especially when it comes to the final legs of concussion rehab, like getting someone ready to go back to football or soccer. And what does that look like? How are you specifically testing them, training them? What does a rehab day look like with you? But that could be for a different podcast. So at least for now, this was a great crash course.
Yeah, no, sounds good, Christian. Glad we could sit down and talk about it. If anyone has any questions about it or wants to clear any loose ends up, feel free to reach out. Would love to chat some more, but appreciate the conversation.
All right. Thanks, dude.
Thanks, Ben. See ya.